So this paper is titled Engineered Adoptive T-Cell Therapies for Breast Cancer, Current Progress, Challenges, and Potential, written by Diego Chamorro and their colleagues Lawrence Gomez and Valentina Hoyos. So as it is already known, breast cancer is the predominant form of cancer in women, and the engineered adoptive T-cell therapies is one form of immunotherapy that uses the patient's own T-cells and modifies them to target specific cancer antigens. Though many preclinical trials have shown promising outcomes, more data is needed to translate these results to the clinical phase. So this paper is a review paper whose objective is to summarize the key target antigens for breast cancer, the challenges associated with engineered adoptive T-cells in the tumor microenvironment. The authors also suggest some strategies to increase the persistence of engineered adoptive T-cells in the tumor microenvironment. And finally, we will discuss some current clinical trials results in engineered adoptive T-cells in the scope of breast cancer. So as an introduction to this paper, the authors first provide this table that summarizes the key differences between the two types of engineered adoptive T-cell therapies, which are chimeric antigen receptor T-cells and T-cell receptor T-cells. So the first important difference is that TCR T-cells are natural receptors. However, they have been modified to have increased specificity to certain antigens. However, CAR T-cells are fully synthetic receptors. Moreover, TCR T-cells recognize antigens expressed on the MHC complex. However, CAR T-cells are MHC independent. Importantly as well, TCR T-cells can recognize antigens intracellularly as well as expressed on the cell. However, CAR T-cells only recognize cell surface antigens. And importantly, CAR T-cells have a higher risk of cytokine release syndrome. So the target antigens for breast cancer are divided into three categories. The first one are the tumor-associated antigens, which are expressed both on on cancer cells as well as somatic cells, and this is why they impose a high toxicity risk. Therefore, the antigen must be very highly concentrated on cancer cells to be able to use this type of antigen targets. The second target could be the cancer germline antigens, which are expressed on germ cells. However, they are abnormally expressed on cancer cells because of hypomethylation. And so they are desirable targets because they have a restricted expression on cancer cells. And finally, tumor-specific antigens are expressed only on cancer cells, and they are usually ideal targets for TCR T-cells because these T-cells can recognize point mutations, sparing the wild-type antigen. And the most common tumor-specific antigens are the neoantigens. And neoantigens are usually specific to certain patients, so it's a precision type of approach. However, there has been exploration of some driver mutations, which are neoantigens that are present in a wider scope of breast cancer patients that could be targeted. However, with antigen targeting comes a lot of challenges. For example, that some cancer cells can lose this antigen expression and therefore become resistant to treatment. Therefore, the authors move on to suggest two approaches to this issue. The first one is to actually induce the expression of certain target antigens. For example, the cancer germline antigen. This could be induced by allowing for hypomethylation or inhibiting DNA methylation in cancer cells to express these antigens and therefore be targeted. A second approach is to allow for so the chimeric antigen receptor will have to recognize two antigens before being activated, and so this will reduce off-target toxicities. Next, we will discuss some of the problems that the engineered adoptive T-cells must overcome in the tumor microenvironment, specifically the immunosuppressive environment. So some elements are the T regulatory cells, which suppress T cells by the secretion, the cytotoxic T cells, by secreting interleukin factor 10, tumor growth factor beta, and adenosine secretion. And the T regulatory cells, along with the engineered T cells, can compete on interleukin-2 consumption. And so some of the targets to reduce T regulatory cells is to deplete them from the immune system by targeting specific surface molecules. However, no current preclinical trials have focused on this particular approach because many of the antigens on T regulatory cells are also expressed on the T cells that will be used as adoptive T cell therapies. The second immunosuppressive element are the myeloid-derived suppressor cells, which also secrete metabolic factors, oxidative species, and PD-L1 to inhibit the effector effects of the adoptive T cell therapies. And so this point I will later discuss in greater detail. And the final element in the immunosuppressive environment are tumor-associated macrophages, which secrete many factors and inhibit the cytotoxic cells, but also express death receptor ligands that stimulate inhibitory signals in the T cells. Now, interestingly, many of the tumor-associated macrophages antigens are also antigens expressed on breast cancer cells. So therefore, the chimeric antigen receptors that target these antigens, such as the receptor tyrosine kinase AXL and ephrin receptor A10, these chimeric antigen receptor T cells will not only be targeting the breast cancer cells, but also the immunosuppressive tumor-associated macrophages. Now, moving on to some non-immune tumor microenvironment challenges. The first one includes the extracellular matrix. So the engineered adoptive T cells must overcome the collagen alignment, which could be targeted by the scoidin domain receptor 1. Another significant point that the authors discuss is the use of macrophages rather than T cells as engineered immune cells that could target cancer cells. So for instance, a preclinical study that used macrophages expressing an anti-HER2 chimeric antigen receptor inhibited the tumor growth in an immunocompetent model. And this is because macrophages can secrete metalloproteinases that will degrade the ECM and allow for greater infiltration of the immune cells. The second element are the cancer-associated fibroblasts, which usually remodel the tumor microenvironment and promote angiogenesis and malignancy. So the authors suggest targeting signaling molecules such as interleukin-6 and PD-L1 associated with these cells in triple-negative breast cancer. Also endothelial cells, which cause angiogenesis and promote the invasiveness and the metastases of the cancer. These cells could be targeted by using, for instance, the endothelial marker 8 and the vascular epidermal growth factor. And finally, metabolic conditions like hypoxia, the depletion of nutrients, the active oxidative species, and adenosine and lactate can all inhibit the activity of the effector T cells. So in order to address these issues, the authors summarize some important techniques that will help the engineered adoptive T cells to increase their time and duration in the tumor. So the first one is to actually, so this is the CAR T cell, is to have a transgene that will allow for the secretion of stimulatory cytokines that will stimulate cytotoxic effects in the T cell. Another method is to have a constitutive reactive interleukin-7 receptor, which usually promotes the immune cell proliferation. So this will not require signal. The third method that is suggested is to have switch receptors. Switch receptors usually will turn an inhibitory signal that usually suppresses the T cell into an excitatory signal. So for instance, there's an interleukin-4 exodomain that will be turned with an interleukin-7 endodomain, which is, so it's an inhibitory signal turned into an excitatory signal. The fourth suggested method is to knock out every antigen on the T cells that will bind to immunosuppressive molecules like adenosine. And finally, here we have the TR2 receptor on myeloid-derived suppressor cells. So TR2 receptor is the T-related apoptosis-inducing ligand. So once the chimeric antigen receptor of our T cell binds to this ligand, it will trigger apoptosis in suppressor cells, as well as trigger a stimulatory response in the CAR T cell by this domain. And so moving on to the final section of this paper, which discusses some current clinical trials and the results that have used engineered adoptive T cells So it aims to basically just look at the current data in the literature and to see what therapies have been proven effective and which ones are toxic or safe. So both of these studies were performed by the same group. The first one was published in 2017. It's a phase 01 clinical trial. This one uses CAR T cells that target this antigen, this c-Met antigen. There were 6 total patients, 4 of which were triple negative breast cancer or ER negative breast cancer. And so in this study, there was not wasn't specified whether lymphodepletion was used, and there was no clinical response that and all the cytotoxicities that were detected were deemed unrelated to the drug that was tested. However, this was non-detectable after 24 hours. Now, the same group published another study in 2023 that had 7 total patients, 4 of which were triple negative breast cancer. 2 of these patients showed stable disease, and other 2 showed progressive, and there wasn't any toxicity that was measured in these patients. And so therefore, the authors conclude that this method is a safe and moderately effective target immunotherapy. So another study that uses CAR T cells, however, targeting a different antigen, which is the ROR1 antigen. This study used 21 total patients, 3 of which were triple negative breast cancer. And so 2 out of these 3 patients had stable disease, and 1 of them had progressive disease. However, out of the 2 which had stable disease, 1 of them had a response after increasing the dose level of the CAR T cells administered. And these 2 out of these 3 patients as well had an expansion of the CAR T cells in their peripheral blood. However, at their peak expansion, they started to lose their capability of secreting stimulatory cytokines, and they started to upregulate inhibitory receptors. So the authors suggest that this is a safe method because even though they had at the beginning they didn't have any toxic effect, but the problem is that these CAR T cells weren't able to endure in the tumor microenvironment after expansion. Now moving on to TCR-T therapies, a study published in 2022, it's a phase 1 clinical trial study, which had 9 patients in total, one of which was a breast cancer patient. So this study was performed with lymphodepletion, and this patient did not develop any type of cytotoxicity. And this patient actually had 25% expression of this antigen, that was the target antigen. And their CAR T cells did not respond well. However, in the other 8 patients who are not breast cancer patients, they had a higher antigen expression, so it was expressed at 75%. And in these patients, they had a 30% tumor regression and decrease in tumor size. So the authors suggest that the reason why the breast cancer patient did not show a positive response is because their antigen density was low. And so there needs to be additional clinical data to evaluate this particular immunotherapy. Staying with TCR-T cells, a different antigen, the MAGEA3 antigen, a study published in 2017, it's a phase 1/2 clinical trial, having 17 patients in total, 2 of which were breast cancer patients. This was administered with interleukin-2, the doses of TCR-T cells. Now, both of these patients had grade 4 cytotoxicities, and so they didn't have any response to this treatment. So this particular target is known to be cytotoxic, and it doesn't have any efficacy in the treatment of breast cancer. And the final category are TCR-T cells that target neoantigens. In this case, it was a study that used 1 breast cancer patient and targeted the p53 antigen in particular. Now, this patient had standard lymphodepletion, and they did not have interleukin-2 administration. Now, the patient had a grade 3 cytotoxicity, had a grade 3 cytokine release syndrome. However, it was resolved after hospitalization. Despite this initial distress, the patient exhibited a 55% decrease in tumor burden at 14 weeks post-treatment, and even at 4 months, these TCR T cells developed into males. However, at 6 months, the cancer cells started to lose the HLA expression, and therefore they were unrecognizable by the TCR T cells anymore. So in the first 4 months, the treatment was very promising. However, at the end, we started to have resistance to treatment. And so this shows that this type of therapy could be a promising therapy. And so to conclude, the authors first suggest that there needs to be more trials that use humanized mice instead of regular murine mice. And yes, they just mentioned that the results of these trials, whatever they are, they need to be published because they need to guide future research. So yes, I'd like to add something from my part, which is that even though like these trials, they all somehow show promising results, most of them are just done with 2 to 3 patients each trial. So I think that a lot more has to be done in order to establish these therapies as